everyone, thank you so much for being here. This exciting Lunch and Learn. We have Jamal, who's been with us almost a year now.
Coming up.
Almost a year now, and he's going to talk to us about movement as the vital sign that it always should be, I believe. So please welcome Jamal Beachy.
Yeah, so today we're going to talk about movement and hopefully maybe establish it as a vital sign so we can have redefinement of health through movement literacy in all care, but particularly orthopedic care, because that's kind of what we do. So some objectives I want to hit are understanding where we're at currently, and I call it an orthopedic epidemic, which maybe is an exaggeration, but I think it's important to kind of understand where we are in the orthopedic world so we know where we need to go. I want to define movement as a vital sign, and if you can establish it as a vital sign, hopefully you can understand movement literacy, and if you can understand how you move, what's good versus bad, then you can build capacity and performance on top of a good movement pattern, and then hopefully we'll define some exercise principles to do so. So that's where we are, the orthopedic epidemic, and again, it's important to know where we are so we know where to go. And when we talk about the orthopedic epidemic, orthopedic trauma is the largest or the leading cause of disability in the United States. In particular, it's chronic low back pain. And so the prevalence of this is about half a million cases of low back in the United States. And that's expected to double by 2050. And there's a great economical impact on this. So it's estimated about a $400 billion loss in productivity when you have an injured worker over the lifetime cost of that. And that's important to know, right? They get injured, maybe they're not gonna work or be less efficient. I care less about that. I care more about that they're going to go back to normal work. But there's also a healthcare financial cost to that. And that's about another $100 billion over the cost of their lifetime, which is huge. Can everyone hear me okay in the back?
What?
Yeah, what? So we have this problem, and I think there are many ways to redefine it and make it better. And I want to talk about body resiliency in part of this. And I think it's important how we talk and communicate and educate to our patients. And there is this side of the coin where patients hear what they want to hear from us, and we have to do a little bit better of making them kind of understand it in a better light versus them just kind of picking all the bad things out of what we're telling them. But body resiliency is the ability for the body to heal and to adapt and overcome and do its job regardless of its deficits. And hopefully there are no deficits, right? They get better, they rehab, and they perform, but we need to do better at educating. When we look at low back pain, specifically, we have a lot of data out there, and some of this data is pretty old, like 1998, but we're always updating. We have all this data that supports that most people will get better when we're talking about back pain, even without the need for intervention, if it's an acute problem. And so we have all this data supporting, hey, they'll get better, but it's the leading cause of disability in the United States at 500 million cases and expected to double. So why is there this conflicting information? And I think some of that is you'll never prevent a traumatic injury, right? Someone falls 20 stories, like they're gonna get hurt. But we can improve the way we treat chronic overloading problems, and a lot of that's caused by bad movement habits or bad movement patterns, which we're gonna talk about today. I do wanna point out we have these clinical prediction guidelines. I think all in healthcare, but in PT particularly, it's kind of like an algorithm. Someone comes in, and if they hit certain data points, we know that they'll have maybe success in a certain treatment that we choose for them. So with back pain, we can predict that they have a 92% chance of success if they hit 4 out of 5 criteria, and one of those criteria is if they're coming in within 16 days of injury. This is great if we can get them in 16 days, but a lot of times that doesn't happen. They go through, they have the trauma, maybe they go to the ER sends them to orthopedic or primary, maybe they go to injections, imaging, and maybe by the time they get to us, it's a couple weeks at best. At worst, sometimes it's a couple months. And so, again, can we redefine this orthopedic curriculum or care or continuum to get them more efficient care? Not necessarily better, but can we get them to where they need to be more efficiently? So I put these in here because I hear this pretty frequently, multiple times a week from multiple patients. They're always coming in, they're saying, someone down the line, and again, is this what they heard or what they were told? I don't know. But it's the worst I've ever had. The doctor said it's the worst spine I've ever had. It's the worst arthritis they've ever seen. The imaging says degenerative disc disease. It's all the list of negatives, okay? Hopefully we're seeing them within 16 days, and if we are, great. Best case scenario, we can get them better. But if they're coming in with all this negative impact, this psychological factor, well, now we got to clear the muddy water and get their fear factor down so we can get them to move better. And if they can move better and they're not afraid to do that, they're going to have better outcomes. And so my advice here is, again, better education. Think about what you're saying them. Try to give them accurate diagnosis. Give them an accurate diagnosis, but put it in a better light, right? Body resiliency. So I was told I have degenerative disc disease. Okay, that might be true, but it's a normal aging process, and it's seen in 77% of asymptomatic patients. So just because you have a finding on imaging doesn't mean it's going to be a pain generator. I was told to never lift over 5 pounds. A gallon of milk weighs 9. So how much are you going to limit yourself? Most people are going to lift more than 9 pounds. They want to lift their grandkids. They're going to lift a case of water. So maybe not now you can't lift it, but hopefully by the time we're done, we will. My doctor says it's the worst spine they've ever seen. Again, they might just be hearing that and it's not true, but 5 to 10% of low back pain is actually due to some abnormality, some actual pathology. So what's the other 90%? Hopefully it's something mechanical, muscular, something we can get them to bring the fear down of movement and get them to perform better. I was told I need an MRI to do PT first. Oh, but I have to do PT first. I don't want to side with insurance, but this is true. And it's probably because insurance doesn't want to pay for it. I'm not on the insurance side of things, but it's more because patients do better with conservative care and therapy, and so the need for the imaging doesn't necessarily have to be there, right? We can get you better without seeing what's wrong on the imaging. So that's where we are. And how many more things does this person have to go through to have more efficient care, get them to the right practitioner, whoever it may be, rehab, chiropractic, massage, doesn't matter. I don't care who you go to as long as you get better. But how can we get you there more efficiently? This is more to keep me on track, so I just want to check these off as we go along. So hopefully you kind of understand where we're at with the epidemic. And now we're going to move on to where we need to go. So my argument is, can we prevent the trauma from happening at all? And again, you're never going to prevent a traumatic injury, someone falling 20 stories, but preventing those chronic things over time, repetitive injury risk, the stupid things that probably happen and should be happening a lot less. And I think we can do that with preventative movement screens, a functional movement screen. And so if you can move well, if we can establish what moving well is, then you'll learn movement literacy and what bad is, and then you can do all the things you want to do. Move often, recreation, exercise, wellness. Can anyone rattle off some vitals, normal vitals?
Less than 120 over, less than 80.
What's that for?
Blood pressure.
Okay, blood pressure, what else?
Temperature, 98.6.
Nice. Other, heart rate, good. Any others?
Gait velocity.
Nice.
Respiratory rate.
Yep.
Oxygen saturation.
Good. So I think those are the main ones when you look at all the literature, and when we go to have screening, that's what they assess. There are two other ones that aren't necessarily that prevalent, but we talk about pain, at least in rehab. Everyone's kind of talking about the pain when they're coming to a medical facility, and some people will argue that it is a vital, but also blood glucose. What about movement? Does anybody know of any movement vitals?
Walking speed.
Yeah, good. So our phone.
Motion.
Range of motion, yeah. I don't know if you know, but if you have an iPhone, the health app will actually track your cadence over time It'll say if you have an asymmetry right to left. So it's pretty cool data out there, and it's available. But all these have some number attached to them and some normative value. But movement doesn't necessarily, I mean, yeah, gait velocity, range of motion, that's all good. But how do we make that a little more functional? So we'll talk about that as we go along here. What about vitality? Does anyone understand what that means or have a good definition? It's pretty loose. I think you could use a lot of phrases to define that. I like this one to the right, the state of being strong and active. And I think if you move well and you have the ability to build good capacity on top of good movement, then you will be strong and be active and hopefully through the rest of your life. But how do you get to vitality? First, you move well. And I should take a step back. So a lot of this phrasing in this functional movement screen is part of Functional Movement Systems, which is a company. And it's this cohort of practitioners, PTs, chiros. There's some medical doctors that help with all these studies and this data. And so they've established this. And so they want to say that you should move well, period. And it's very definitive, right? That should always happen first. And the period is very intentional in that it should be a biomarker. Functional movement should be a biomarker. So to understand how you move and how you move well is the starting point. And once you move well, then you can move often, and they leave move often open-ended, right? It's what you want to do at that point. First, you're going to do what we think you should do because we know that that's the good way to do it, and then you can do all the things, the fun things that you want to do. And then once you're moving well and moving often and you're doing the things you want to do in exercise, then you get all the health benefits of exercise, improvements in resting heart rate, improvements in blood pressure, lowers depression, and improves immunity, improves endorphins. So those are all the benefits that we want to get out of exercise. So how do we quantify movement? You guys already rattled off some stuff, so I won't make you sit here and do it again. But we're going to talk about the functional movement screen. And I want you to know that it's movement competency that we're screening, and it's a screen and not an assessment. It's a screen, not an evaluation, and those words matter because anyone can do this screen if they have the training to do it, and it's not a medical evaluation. This will not find or tell you what's wrong. It's just going to tell you that there is something wrong, and if you have pain or a bad problem, it's something you need a more specific evaluation or assessment to dive a little deeper. So it's movement competency versus movement health. These are the 7 movements of the functional movement screen, and this has changed over time. This is kind of like a bird dog, if you guys know what that is. And the previous version of this test, they were doing kind of a normal bird dog motion where it was opposite arm. And then they found that it was too passable, right? It wasn't giving them good enough data, so they changed it, which is good. So I feel like we have this board of people that are always constantly updating the criteria based on a current practice. So we're going to start left to right on this because it's how it is, but this is not necessarily how we test it. This is just showing you that we go from an easier position to a harder position down the line here. So we start in a nice stable position on your back, you're supported by the ground, and it's assessing whether or not you have enough stability to maintain being on the floor, but also move one side of the body. So that's a lower quarter or lower body mobility assessment. And then this is the upper body assessment. And then we get into more challenging positions. It requires a lot more stability to perform these. Can you balance on one side of the body in this position and move the other side? So it's assessing stability and mobility. And then even to a harder position, the push-up, which is not a standard. This push-up's really hard. I know a couple people in here have done it. For men, you have to like almost push up from a Superman position. It's very hard to get a good score. And then your hardest positions, inline lunge. Do you have enough balance to stay on this board? Do you have enough ankle motion to stay in line over the board? And do you have enough core stability to maintain trunk stability across the board through dynamic motion across that board? And even more stability when you take it standing, and then eventually a squat. A squat seems pretty natural, and it is. But to do it overhead, to maintain an upright posture, to have enough mobility to get to the depth of the squat that we want is a very hard thing to do. So how do we quantify that? It's scored on a 3-point scale for each maneuver. So best score, if you score 3 in every category, you get a 21. We don't need a 21, we want a 14. So if you score a 14, it's because you have 2s in every category, and I'll show you a score sheet in a second. And that means you're symmetrical on each side, and you've passed each movement, and then you can own that movement. That's yours to build capacity on top of. If you score a 2 and a 1, you're asymmetrical, and that's a problem. Even though you got a 2 on one side of the body, you're deficit on a 1. And so that's something we want to correct. You don't own that, right? Something we want to either correct, develop, make you better at that to get you symmetrical 2s. And 0 is a fail-safe. So this screen can be performed by anyone with the training. It doesn't have to be a medical practitioner or a rehab person. It doesn't have to be a physical therapist. The benefit of me doing it is I get to look from it from both lenses, the lens of the screen, but also the lens of a rehab person. But if someone scores a 0, it's because it was painful. They could perform the squat perfectly and meet all the standards, but if they say it's any slight of pain, it's an automatic 0. And that's just to get them to someone that can roll out why it's painful, or roll in, whatever it may be. So why these movements? Why these 7 movements? And that's based on something called the neurodevelopmental sequence. It's how a baby is born. And if they have no motor development delay, they're going to go through these milestones over the years, the months to years, and they just kind of innately know how to do this. I always kind of compare it to computer software. You go to the store, you buy a computer, you boot it up, and it just does what you want it to do. Babies are the same. You coax them a little bit. But by the time they get to a squat, nobody teaches a baby how to squat. They do it every time, and it's perfect. And so why is that? It's because they already have that programmed into them. When someone gets injured, as we get through these and you're running through life and you get injured, you lose that ability because something hurts and you're finding a new way to do it and be more efficient. And so I kind of established that like a virus. You walk normal, you get injured, that's a virus. And then you start doing weird things like this. But then the funny thing that happens is people walk like this and they think it's normal. They come in and they're like, oh, I walk fine. Well, this is a problem. They don't have any pain, and long after the pain's gone, they're still walking like that. So why is that, right? It doesn't hurt to do it, but they've created this habit. And so that's kind of like motor planning. And if you zoom out, you can kind of see how these relate: crawling positions, squats, and so it's just the underlying basic functional movement patterns. And if you can perform these well, then you can do the higher activity, sport performance, dynamic activity. So this is a score sheet. I know there's a lot of data on here. You really only have to pay attention to this column. This is just listing each movement. Here's the raw score on each side of the body. No matter if you score a 2 and 1, like 2 on one side, 1 on the other side of the body, you get the lowest score as a 1. So you tally these up, and then you get the final score here at the bottom. And again, we're looking for a 14 at minimum with symmetrical 2s. You can score better than a 14, because some of they're all based on 3. So like a deep squat, you could get a 3, and that would push you over 14, and it would still be a bad score even though it's better than 14 because you have asymmetry somewhere in the body. So we'll take your final score, we'll run it through an algorithm. This algorithm is getting better each day because we're giving it more data points the more we test it. But it'll compare you against people of your age, your gender, your sport if you want to, a recreational pro, like what level of sport. If you have a certain job, that is sometimes in there that we compare you to. And then it'll categorize you. So significant, moderate, and mild. And LOT means loss of time from whatever you want to do. So it's predictive. If you don't move well and you're scoring a certain thing, a certain score in a certain category, that potentially you could be at a risk of injury up to 50 to 60%. Good. So some misconceptions about the FMS. It's not diagnostic. So people will say, well, what's it tell you? It doesn't really tell me much except that something's wrong. It's a little different with me doing it because as you're squatting and you're doing something weird, I have the rehab lens. So I'm like, yeah, you probably don't have enough ankle mobility, or maybe your thoracic spine's a little tight. So it's a little different when someone in the therapy world does it, but it doesn't tell us what's wrong. I just know that, hey, you didn't do that squat very well. Well, now we need to break out your ankle. And is your ankle moving well? Is your T-spine moving well? Do you have enough stability? And then if we fix that, great, we'll squat again and see if it improves. So it is not diagnostic. It does not measure sport performance. This is not a sensitive test to dynamic activity. This is a movement screen. It'll assess, do you have the capacity or the ability to put capacity on top of good movement. There are other tests out there. We can measure torque, we can measure force, we can measure sport-specific activities, but this is not that. And athletes always, and weekend warriors and PTs, they always want to get a 21. We don't care that you get a 21. We'd rather you get a 14 with symmetrical twos than have a higher number. Symmetry is important, and the more symmetrical you are, the least likely you are to get injured. So hopefully we've defined movement as a vital sign. 14 with symmetrical twos is the numerical range that we want. And if you can do that, normally as you're doing this screen, you're kind of, I should take a step back. Like a squat, for example, if you do a squat on this screen, it doesn't feel natural to do it. It's because I'm putting you in a certain position because it's standardized, and it feels very unnatural to do that, but it's assessing the max stability and the max mobility you need to perform that motion. And so when people are doing this, they say this feels weird. Well, it does, because we're stressing that to the max. And so they're understanding what good should feel like, or you're telling them what good movement you should do, but they're also feeling that this doesn't feel the greatest. And then hopefully you can do a correction. They do it again, they're like, yes, this feels much better. So understanding movement. And then if you move well, then you can build the capacity. You can do the strength training, you can do the cardio on top of that, but you have to move well first. And so I think we'll dive into some exercise principles now. We've established the number now as part of vitals. And so we can move often, and the American College of Sports Medicine and CDC recommends that we should be getting at least 150 minutes of cardio a week and 2 full body workouts a week, resistance training. And a full body workout is 8 to 10 muscle groups. I would say most people are below standard for this, and I think we can all do better, myself included. We'll talk about cardio a little bit. I feel like most people have a pretty good sense of this. A lot of people have access to wearables, smartwatches, rings, straps, phones, and so it's very good at giving you a pretty accurate heart rate. It's also giving you pretty accurate zones to be in, like my Garmin. Right now I'm detraining. Normally I'm unproductive. But it'll tell you like if you're in a good zone or not. And so these are plastered all over most gyms. RPE scales are in the gym, and so you have that to compare on. We'll dive into this deeper if someone has questions, but I'd rather spend the bulk of the time on resistance training because I feel like that's kind of a loose cannon. So what do you think about when you perform resistance training?
Weightlifting.
Getting jacked, yeah.
Yeah, okay. How do you get jacked?
Lift heavy weights.
Okay, how do you pick a weight?
It's based off of your 1 rep max.
Nice. Okay, I didn't expect that answer. Okay, good. And then based on your 1 rep max, which we'll explain here in a minute, how many sets and reps?
Well, it depends what you're training for, I think.
Good. These are way better answers than I was anticipating. Okay, good. So you want to get jacked?
You want to get big, huge.
Okay, so let's say you're going to strength train then. How do you pick a weight based on your 1 RM versus your sets versus your reps? How do you plan that out?
So sets and reps would probably be 4 sets of like 5 to 6 probably.
Okay.
And then your percentage of your 1 rep max, I've never really gotten that technical with it, but I'd assume it's probably like 70 to 80%.
Cool, that's a good answer. We'll kind of dive deeper into that. Most people come in and they say, I'm going to do 3 sets of 10. And I always ask my patients why. They have an understanding that they should do 3 sets of 10. They don't always break it out to 3 sets of 10. They think 3 sets of 10 is 1 set of 30. But they at least have the understanding that there's a number associated to that, which is half the battle, so it's good. And a couple principles I want to talk about, which will make this make more sense, hopefully. So there's the SED principle, which means specific adaptations to impose demands. And that basically means, is the demand of the load, the demand of the lift, the demand of the workout, is it going to be enough to cause adaptation that you want? So if you want to strength train, are you going to be at 85% of your 1 RM? And is it going to create that adaptation? That's what that principle is saying. And then once you establish that, you need to maintain progressive overload over time. Strength adaptation takes a very, very long time to do. And so the body continuously wants change. It wants challenge. And if you do that with the right amount, the right dose, then you will progressively overload and you will see results.
I started weightlifting, both my husband and I, in my 80s because I had osteopenia. I was 85 the first time I competed. I remember my first meet. I was very nervous, scared shitless. One of the coaches said I had perfect form, and I said, thank you. Had no idea what perfect form was. Going to the first national competition was very humbling. When I competed, the roar of the crowd was unbelievable. I thought, I don't deserve this. I haven't done anything out of the ordinary.
I haven't done anything out of the ordinary. I feel conflicted with her statement because if I saw my grandma doing that, it's pretty out of the ordinary for her to do that, which is cool. But on the other side of that, it should be normal, right? Everyone should be doing that. Maybe not powerlifting, but like to go to the gym at that age should be a normal thing, but it's kind of like taboo. So I feel conflicted, but so what does this really mean? You were talking about 1% 1RM, and so that just means repetition max. So if I give you 100, for easy math, we're gonna use 100 pounds. So if I give you 100 pounds and I tell you to lift that one time, or as many times as you can, and you were only able to lift that one time, max effort, couldn't do another rep if I put a gun to your head, that is your 1RM. In therapy, we don't always assess this, we estimate it. And you can go by feel too. It's a risk reward. You could test it, but there are risks to that. And so if we say that your 1RM is 100 pounds, if you want to truly strength train, that load's got to be 85% of that or more. So 85 to 100 pounds, okay? And we'd anticipate I think you said about four reps, which would put you under 6 and expect 2 to 6 sets. Most people do 3 sets of 10, which puts them here. 3 sets of 6 to 12 reps. That is called hypertrophy, which is just the fancy term for increasing muscle fiber size. And I'm gonna talk about females just a second about this because they come in, I give them heavy weight and they say, I don't wanna get bigger. And that is what hypertrophy means, and that's the goal, that's the adaptation. But females typically, unless they really, it takes a lot of effort to get big, right? And so if you're not eating enough protein and you're not lifting really heavy and really consistently, you're not gonna get big, but we wanna develop hypertrophy because that's gonna build a nice solid foundation to put functional strength on top of. And these training adaptations take weeks to months to do over time. In rehab, we're not even on this chart. People come in, we're dealing with pain, we're dealing with movement problems, and we're trying to build just exercise tolerance for them. And then when they can, we gotta get them here. So let's blow this hypertrophy model out a little bit. And so we're just taking this gray zone and expanding it here with a couple lifts. They're saying at 80% of 1RM, which is right in the middle of this zone, and they're saying 4 to 8 reps, which puts them right in the middle of 3 sets of 10. And we're going off that 100 pounds. So if I tell you to do 3 sets of 10, actually, let's take a step back. When someone's coming in and I'm just telling them, hey, do something, like here's an exercise, let's just do 3 sets of 10, I'm being pretty vague. And I just care that they're doing something because something's better than nothing if they're moving well. And so we'll start with this 3 sets of 10, okay? And then over time, as they get more confident, they're doing the exercise correctly, they're looking good, mechanically sound, I want them to be a little more specific. I want them doing 3 sets of 10, but when they're tracking it, they're tracking set by set versus saying, hey, yeah, I just did 3 sets of 10. And as we make it more challenging, as this number goes higher and higher, I expect that rep range to get less over the sets. It's getting harder because they're getting fatigued. And hopefully they have the competency to know what a good movement and a good rep it is, versus a bad one, and they should be stopping the moment they can't control it and have a bad rep. So they did 10, 9, 7. And when someone comes back and they're telling me, hey, I did 3 sets, but by that 3rd set, I could only do 7, I'm like, good, that's great. You failed in a good way. Your goal was 10, you got 7, we're on the right track. If I tell you to do 3 sets of 10, and you come back and you said, yeah, I did 3 sets of 10, and then we go through it and you do 30 in a row, that's a very different thing. That's like giving you a bottle of antibiotics. I say, take 1 pill a day for the next 30 days, and you take the whole bottle. It's a big exaggeration, but it's kind of the same principle. Like, this is a certain dose of exercise. 1 set of 30 is muscular endurance. 2 sets of 15 is still muscular endurance. 3 sets of 10 is hypertrophy. 2 sets of 6 is strength training. So there's a certain dose for a certain adaptation. When you compare hypertrophy to strength, the numbers change. Instead of 80%, we're doing 100% of 1 RM. Again, that's a big lift, probably not a rehab candidate. This might be an athlete, but they're doing 1 max lifts for 6 sets. On average, that might happen once a week or once every couple weeks if they're doing that. More likely, they're probably sitting around 85, 90%, and they're working more reps over sets. But I just wanted you to see the difference between an example of hypertrophy and an example of strength. This chart kind of illustrates the training adaptations over time. And I said it takes a very long time to create strength and hypertrophy. But in this honeymoon phase, this first short column here, this is where most of our training studies happen. This is where, like, the time frame that we get a lot of data from, and it's about 8 to 12 weeks. When you talk about like New Year's resolutioners, they start in January, and a lot of them fall off by March. And it's probably multifactorial, but I think a bigger factor is in those first couple weeks, they're consistent, they're motivated, they're doing, which is awesome. And then something happens as they get later through the months, the weeks. And my guess, this is all anecdotal and just kind of my personal opinion, I have no data to necessarily back this up, but I've experienced this before. You get all these gains in the first couple weeks, you're feeling good, you're going in, you're changing the weight stack heavier and heavier, you're running further, and it's because you have all this adaptation that's happening, but there's no structural muscle adaptation happening until several weeks, more weeks down the line. Everything that's happening is neural. Your brain is finding adaptation, it's increasing its conductivity to the muscles, it's increasing neural adaptation, it's giving you more motor units, all these good things that need to happen in order for your muscle to develop, but it has to happen first. And if you can reach it to this point, you're gonna see strength gains if you're following the SED principle, if you're doing progressive overload. You just gotta give it the time, the recovery, to let that muscle catch up to everything else that's good that's happening. So I think this is just an interesting chart. So my point is, when you start, consistency's hard, but if you give it if you give your body what it needs, it's gonna adapt. It just takes the time to do it. In the world of therapy too, a lot of times patients are kind of discharged in this area. You get them feeling better, they're moving better, and they're like, I feel better, I'm done. And some of that's insurance, some of that's just the world of healthcare, but we gotta give them the education to say like, hey, you're doing better, but you could be way more better if you just keep going with this. But then a lot come back for the same injury because it just doesn't happen. So we need to do better with that. So adaptation takes time and consistency. Again, this is a pretty elaborate chart. This is more like sport performance. And so when we look at training athletes, this is called a periodization model. And so it's over time, right? So if you took an axis out here, it's over time. And these might be months columns. They might be several months columns. It just depends on the athletes and their goals. My point here with this chart is that it takes time, but also it's cyclical. You could stay in one category your entire life and that'd be fine, right? Most people go to the gym, they pick a weight, they do 3 sets of 10 because they can do it. It feels good, they feel happy that they're in the gym. Something's better than nothing and I'm happy with that. But my argument is every decade of life we're combating decreasing muscle mass, we're combating like osteoporosis, right? So why not be better? Why not put yourself higher so that way if there's a negative outcome down the road, you're gonna be ready to battle that. So you might stay in this hypertrophy model for a couple weeks, couple months, and then you'll transition to power for a couple weeks, couple months, depending on the athlete or the person. You don't have to be an athlete. Daily people like maybe some of us, we're not going to have a competition, but you're still going to peak. You're going to create adaptation, you'll peak, and then you're going to peter off, and that's normal, it's cyclical, because you need active rest to fully develop the adaptation that you just trained for the past weeks, months to a year, and that's normal. And so you'll recover for a couple weeks, you'll do more cardio, you'll offload the weight a little bit, give your body some rest and recovery, and then you're going to start over. But instead of that 100 pounds, you're going to do 120, 150. It depends on how you adapted and trained, but you're going to have some sort of improvement, and then you start that cycle over again. I know that was a lot, and maybe I didn't hit everything, and I know some people are going to have questions, but hopefully that's a better deep dive into some strength training and some hypertrophy training. And again, we can go back to cardio if people have specific questions. I'll do my best, but questions about anything? Yes?
Do we ever, this is all after an injury?
Is this?
Some of it is. I mean, when they come to you
Oh.
here in the hospital,
Yeah.
it's because of the injury they're
Cor-
here. So
cor-
I don't hurt myself, not here.
Yep.
Okay. How do, is there any way to evaluate someone? Like, a patient just comes in and says, I want to be evaluated so that I make the right movement, so that I don't get the injury.
Yes.
Do we offer such a thing?
Not yet, but maybe let me clarify your question. So you come to me and you say, I have pain or I don't have pain. You don't have pain. I love patients like you. Come to me.
But do you have any?
No. It's like a broken model of healthcare. And this is what I want to change is rehab focuses so much on secondary and tertiary care, right? You coming in with a problem, you've injured something, there'll always be a need for that. But why not stop it before it's a problem, right? If you come in and you're like, I don't have pain, I just want to be better. I love patients like you. I'd treat you all day long. And so yes, that's this. You come in and you're saying you not have pain, I'm going to run you through a functional movement screen and some other things, right? It's not just going to be that. And say you don't have pain coming into me, but I find pain, well then you're going to kind of go on the rehab side. We're going to tease that out a little bit, why you have pain. Normal life things, you're not feeling it, but if I'm stressing you to the max and you're having some sort of pain factor, you got some underlying problem, it's just not affecting you yet. And so let's change that before it's a problem. So I think that maybe answered your question? Yeah, if you don't have pain or problems, yeah, we can treat that. How we navigate it here at Grand River, I'm not quite sure yet.
That's what I was wondering, do I actually have, like, go to my primary and say, hey, I just want to get this done, and they're like, yeah, it's okay.
Because you don't have to go to referral to come to PT.
Yeah.
Oh, you
You're on
don't?
our insurance.
Why is that? Because my state practice, PT state practice says direct access, right? Anybody can come to me as long as they're not Medicare, Medicaid.
That's, if you're on the Grand River, if you have our insurance, normally you have to have a referral to come to PT, you do not here.
Okay.
If you're on our insurance, you can go to PT without it.
Okay. So that's good. I didn't know that. So that opens some access. Yeah. So that's good. Answer your question.
Yeah, I think so.
Do we need to elaborate a little?
I just kind of wanted to know maybe
Yeah.
attitude or that I didn't know that.
Yeah.
It just seemed being proactive with patients.
Yeah.
And maybe you're so busy with problem cases that you don't have time for
No.
proactive cases.
It's your time. I'm here regardless, right? So if you're on my schedule, I'd rather treat 10 of you than somewhere where I have to deal with pain, because pain is so limiting. I mean, we got to treat it. We want to get people out of pain, but there might be a delay in what we can actually do just because something's painful. So if you don't have a painful problem, yeah, let's work on it. Yeah, come see me.
Give that.
Yeah. Even if ideally, if someone does go through the rehab course and they're doing better, they're moving well, and they have no pain, I'm still going to run them through a functional movement screen at the end of their treatment. I've been assessing it all the time, but I want to give them a number, because when they leave, they're like, yeah, cool, I'm a 14 and I have symmetrical twos, I move pretty well, I can do. But if they get injured again, now we have a baseline.
Well, I guess my next question then would be, if I went to changing lifestyles and I wanted to change my life at that point, and be more fit and everything else, would changing lifestyles say, we're going to send you over to Jamal and he's going to give you an assessment, and then you bring it back here and then we will start there and work from that?
I don't see why not. Yeah, I think that's totally in the wheelhouse of everybody here. Yeah. And maybe somebody else has some input on that. I don't know what they necessarily do over there, but I don't see why that would be a problem. Yeah.
I can add that, and I know Lori knows this, because we've been in many of these, but Changing Lifestyles offers 5 free visits for that kind of consult thing, and then it sounds like if we have a PT concern of our own, whether it's an injury or not, we could make an appointment with PT and that could coincide.
Yeah.
Is
Yeah.
that correct, Carol?
I was just gonna say, so that is if you're on our insurance.
Yeah, that's what I'm
Is
saying.
the
It's only
5
our
free visits,
insurance.
right?
You do not have to have a referral to come to see someone in PT. Okay, so it sounds like those two things could coincide pretty easily.
Yeah. And I think hopefully somewhere in the future, it's just part of like preventative care. Like you go to your primary for your annual checkup, they say, great, you're medically cleared. Let's get you to a therapist and get you physically movement cleared. And it's just part of like the wellness track.
So would that be is there something like this or a program for wellness that we could incorporate into that for employees?
Not yet. I have it back here somewhere in my head. I'm hoping if and when we get a new facility, maybe might be a section of gym we could build something there. Nobody knows this except now you and me. But yeah, that's kind of what I think. Because I like rehab, I like treating people, but I like treating people without pain, right? I like looking at movement and building and developing capacity and performance. Rehab's part of that, but to me, it's more enjoyable to treat somebody that wants to get better and not someone that's just coming to me because they were told to. Which is still
We
important.
need to talk sometime because we are trying to figure out more wellness opportunities and then what is the reward for doing that? Do we give you a break on some premiums? Do we put something into your FSA or HSA? We're still very much in the infancy of trying to do those, but yeah, let's talk sometime about what we can maybe do.
You know where to find me.
Yeah. Me too.
Yeah. Yeah. Anyone else? Yes.
No, I'm sorry. Okay, so I've taken the functional movement screen,
Uh-huh.
which I feel like I don't have pain.
Uh-huh.
But then the screen made me feel like, whoa, I have these deficits I didn't really know about.
That's the point.
It is the point.
Yes.
But not everybody has access to getting that done. So as like an individual person, are there ways that I could figure out if the movement I'm doing, without doing a functional movement screen, but things I could do to figure out if I'm moving well on my own?
Is there a screen you can do at your house by yourself?
Kind of, or things that might, I don't know, signs that might prompt you to say, oh, actually, maybe I should go get screened by a PT or something else.
I think there are. I don't think they're established. Because when I give patients some sort of corrective, I'm usually giving them a visual target to get. That way they don't need me to kind of self-direct. They don't need me to direct them. They can self-direct and they can auto-correct their movement. And so a big thing is dorsiflexion, the ability to move your ankle in space, particularly up towards you. And so that's a big deficit. You only need 10 degrees to be pretty functional to walk normally. And you'd be surprised how many people come into me with all kinds of problems that can't cross their body over the foot because their ankle's restricted. And it causes a lot of problems up the chain. And so normally I'll show them a couple visual targets, one being kneeling against the wall about a fist distance away with the foot, and can they touch their knee to the wall without the heel popping up? And so that's very visual for them, and I know that if they're doing that, they're probably getting about 40 degrees of dorsiflexion with the knee bent. So they need 40 in this position, but they need 10 here, and so I'll at least start them with something that they can track by themselves. So there are little things like that we can compound and maybe compile and put a list together, but I don't think if you went to YouTube and said, hey, what can I do to see if I move well, I don't think there's anything like that exists. There's this, but it's hard to self-assess this because people want to cheat. They don't even know they're cheating, but they're going to cheat. Yeah.
All the different, you have that graph that goes through the different transitions going from like hypertrophy, strength training, the major competition section, your active rest. Is that another term for like muscular confusion? Because I feel like that used to be something you used to hear a lot, and I don't hear about it anymore.
Yeah.
Is that a way to achieve that, like having these different types of trainings you're doing throughout the year?
Sure, I think so. I think you're talking about like when you get on YouTube and they're like, you got to confuse the body, right?
What the heck does that mean?
Yeah, I think they want you to mix your exercises up, right? Like don't stick, if you want to build chest, well, you're not just going to do bench. Bench will get you there, but your body's going to adapt to that. And so they're saying instead of a barbell, maybe do dumbbells, maybe do a chest fly, maybe do something overhead that's incline versus straight out, or do a decline. And so that's what I think what they mean by confusing it. There are some other crazy people on YouTube that you'll see, they'll do like, I forget what they call it, but they'll just take like these long rigid straps and they'll do an exercise and they're just like going as hard as they can into these rigid straps. And I'm like, oh gosh, like that's gonna be a joint or tendon problem down the road. But they seem to be doing okay with it. I think they will also say that's probably muscle confusion. I'm not sure that's the best way to go about it. And again, that's just kind of my personal opinion. I don't have any evidence to back that up, but changing the exercises, you can go back to original exercises, but you kind of always want to vary your workouts. And that might be within like a certain group of like chest. That might also be like, hey, I'm going to take a break from weightlifting for a week and I'm going to go run, or I'm going to go bike.
I'm usually just like, once I get bored, you get bored of the same routine, it's like, all right, now we're going to strength training.
Yeah, and there are different ways to achieve the same thing, right? Like if you're used to doing 5 different exercises, a squat, a press, a row, you can do those in different forms and still have the same outcome. So if you're just looking to get those gains in those types of lifts, how can you change that lift and still get the same outcome? So if you have specifics, let me know. I can print you some other exercises.
I do have one question in regards to cardio, if that's okay.
Yeah.
This is a ton of really, really great information, so thanks for sharing it.
Yeah, no problem. You need that chart?
These different zones, we're trying to run as far as humanly possible, as far as we possibly can.
Yes.
What should our regimen look like for the type of zone that we should be targeting when we're doing our cardiovascular exercise? So like 2 days a week strength training, everything else is going to be cardiovascular.
Yes. So what cardio zone should you be in?
Running, yeah.
And your goal is endurance?
Just keep every year I want to run farther and farther.
Are you XFiz? Yeah. Oh yeah, I didn't even see you come in. You guys might have a better idea of this. I would say green zone. And how do you find green zone? This chart, I think, is based off heart rate max. But there are different training equations. You can do the Carvonin method, which is so max heart rate is 220 minus your age. You take a certain percent off of that, and then that gets you this.
I've got this
Yeah.
watch, which goes off of, it has your zones on there. It'll tell you what zone you're in when you're doing your workout or whatever.
I think if you're looking for strict, I just want to keep running distance. You're probably going to stay in the green zones or lower.
Okay.
But people are going to create variety because you still want to develop power and speed, which is these upper zones, anaerobic, which will give you more endurance over time, right? Like you're not going to sustain up here for 6 miles.
Right.
These are like bursts of sprint. And then this is like your miles and miles somewhere in here.
So maybe just like a day is like you get into the orange.
Sure, yeah, do like sprint intervals uphill. You might do like 6 sets of as fast as I can count up this hill, something like that. 1 session a week or twice a week. And then your other cardio days are maybe very low aerobic zones. Does that track with what you guys think?
That's perfect.
Cool.
And then what are some good ways to like if you happen to have like a parent that's not willing to put in some time and consistency to exercising, what's a good way to trick them? I've tried motivational talks. I've tried yelling at them.
Did you try shame?
I did try shame. I did a lot
Yeah.
of shame actually. Shame was my first one.
Yeah. I feel like
Dollar bill on a string.
So you're trying to motivate your kids?
No, parents.
yeah.
Oh, parents?
Yeah.
Other parents?
It's
my
har-
kids. I can't keep up with my kids.
Yeah, it's hard. I mean, I deal with that every day in rehab. Like they're coming to me with a known problem, known pain, and I'm saying if you do these things.
Well, that's the thing. I can see that it'll become an issue where it's like the tertiary care that you're talking about.
Right.
So it's like, why not try to get ahead of that now?
If you find the answer, come to me, and then we will sell that. No, I don't know. I think it's one thing to have an extrinsic motivator, like you're talking about, like how can I get them to be motivated?
Mm-hmm.
I think your better if you can find them to give them an intrinsic motivator, right? Like, you've done this and now you feel better. That's when they kind of like, yeah, you're right, I should probably do this.
I think you're onto something there.
Yeah, but how you get there is so, like, it is a psychological warfare in that room over there.
Yeah, and it changes with every single person.
Yeah,
right.
correct. So I don't have a specific answer, but if you come up with something, it's $1 million.
No, that's good.
I have another one.
Yeah.
When you're dealing with patients and like you said, they're not motivated to
Uh-huh.
do all the things that you're trying to do. And they come weekly
Mhm.
or twice a week and they keep telling you, oh yeah. And you know that they haven't done any of it.
You're right, we do know. Go on.
I mean.
You're like a parent.
No.
Yeah.
I mean, do you eventually just say, why are you even bothering us? It's not done.
Yeah, I think some people kind of have that tact to them, like they're just kind of blunt about it. I eventually get that way. It's like, hey, I'm giving you what you need to do. It's on, like, people will come and say, I want you to make me feel better. It's not my job to make you feel better. My job is to give you the tools to make you want to be better, right? So I'll be here. I'll be your support for as long as you want it and you're going to do the work. But when you're not doing the work and you're coming back and you're lying about it, that's a hard thing to navigate, because we should be caring, and I do care, but I want them to also care as much as me. So I don't have the answer of how to fix that. Sometimes it's just like, hey, you got to do this. You're never going to get better.
But you never just say, okay, let's.
Some people do. Some people do. Yeah, I don't. I think I'm a little too nice. I want to say that sometimes.
Do you have a good recommendation for, like, if, like, my friend has cardio dialed in, used to do a ton of strength training, is afraid to get back into strength training because she gets so sore, and then, yeah, I just don't even know where to start.
Yeah.
Get back into strength training 2 days a week. I mean, like, I wouldn't just go do a 1 rep max my first day from
Yeah.
strength training.
And I'll two-part answer. You don't have to do a 1 rep max to get that number. You can kind of estimate it, right? So if she goes back, she's like, I want to get back into it, and I want to take it easy, great. Pick a weight that feels good for 3 sets of 10. Something that you know that's not going to make you sore, because doing something's better than doing nothing if you're moving well. And so at least that'll create the consistency of getting back to it, and she's doing something beneficial. And then if you want to estimate 1 RM, you just pick a weight, whatever your training weight is, how many times can I rep that? So let's say bench press, I pick 10, let's say 100 pounds, just for easy math. I can do that 15 times. Well, if he does it, maybe he can do it 30 times. He's stronger. There's some calculators online. You just say, hey, I did 100 pounds. I did it for 30 reps. And it'll say your estimated 1 RM is 200. And then it'll give you percentages of that. And then you can make a better informed decision, like, all right, for this lift, because every lift is going to be different, a different 1 RM. But if I can do 100 pounds estimated on here, it's saying I'll do 20, so I'll try 20. And if I can do 3 sets of 10 there, you're probably on the lower end of hypertrophy. And so maybe the next session you add like 2 pounds or 5 pounds, and then you do that. Okay, I did 1 set of 10, 1 set of 9, 1 set of 7. That's probably an appropriate weight. She's probably going to get sore, because that just is the part of resistance training. But if she does low load for several weeks and just gets back to consistency, it won't be that such that, like, I haven't done anything for months and now I'm really sore for like a week. That would probably be what I would recommend. And if she wants a functional movement screen, send her my way.
How about stretching too? You haven't really talked much about.
Oh, yeah.
flexibility.
Yeah, that is a good question. And so in terms of the screen, it's a balance between mobility, which is flexibility, and stability. And so do you have enough range of motion in the joints that we're assessing to do the movement? And so it's not a very regimented, like, hey, can you touch your toes? But we're assessing it. It is important, and the way you get there is very variable. Yoga, you could do structured static. If you're going to do warm up and go for a run for like 12 miles, you probably wouldn't statically stretch at the beginning. You would do dynamic warm ups, like kind of like you see like football players doing on the field. And then at the end, they do like a long static stretch for flexibility gains. That answer your question? Yep, good question. I did not touch on flexibility. But most people know how to stretch, right? You get yourself into a position, you feel the comfortable stretch, and then you hold that for a long time. How long's long? When I give it to patients, I'm telling them to watch a clock for 60 seconds. in hopes that they hold it for at least 45. Most people will get into a position and hold it 10 to 15 seconds, and they'll do a lot of it. And it's good, you'll probably feel short-term effects, but if you're trying to get adaptation in muscle length, it takes about 45 seconds to overcome the reflex that muscles are protecting your joints. So as you stretch a muscle, one of its jobs is to protect the joint from dislocating. And so it's gonna say, hey, we're stretching, this is aggressive. And if you hold that statically, the joint then kind of says like, hey, I'm safe still. And it takes about 45 seconds to overcome that, and then you'll kind of relax and melt into that. So 3 sets of 45 to 60 seconds.
Just try to hit all the major muscle groups, basically.
Yeah, hammies are usually tight, chest is usually tight because we're always like this. So I think typically what I give is a lot of hamstring, a lot of calf stretching. Again, I'm seeing a lot of low back pain, so that's why I'm giving them this. And then pec stretch. And so stretching here, and then I'm reinforcing strength with a lot of butt and back for that type of patient, but it depends on what you need.
When you're doing the functional mobility assessment, how long are you having people hold like that push-up position, or is it just can you get up?
Yeah.
Or like the
Can you
bird
get
dogs?
up? 1 rep. You get 3 trials, so if you nail it the first time, I'm not going to make you do 2 more.
Gotcha.
But they don't have to hold it, they just have to show can they get up with good form. Yeah. Anyone else? Awful quiet, Mason. Just absorbing.
Yeah.
This is good. This is a lot of good questions.
What would I type into a search engine to find that calculator?
Yeah. Wendy, can I go to your... Did you not listen? I'm doing it. If you go to Google, 1RM calculator. And I usually hit this first link, strength level.
Oh, cool.
And so if you do 100 pounds one time, your 1RM is 100 pounds, but if you want to be in hypertrophy, your 80% is 80 pounds. Obviously that's easy math, so maybe I should pick something, let's say 270. You picked some sort of exercise, 270 pounds. That's probably extreme.
Colin can do it.
I believe you can, right? So if that's your work and you want to put a hypertrophy on and increase muscle fiber size, somewhere around there, that's your working load, anticipated reps. If you're going to work strength, you're going to be somewhere up here, anticipated reps, anticipated load, estimated load. Yeah.
Cool. How do we overcome that feeling of fish out of water when you hit the gym for the first time?
Yeah, I think that's another $1 million question. If you figure that out, you've made it.
Well, I'm there. I just got a gym membership that's paid for by an insurance company.
Yeah.
And I've been several times and been kind of giving up and stopped. And like, you need to start going regularly. It's by the house. It's paid for.
Yeah.
Just go do it.
I think that's a big...
And I ask that more just to be kind of silly, but
No, I think
still have, because I have a disability, when I walk in, people can tell there's something different about me. And it's like, I just have to, it's more self, because I'm not really worried about what they think. I'm just more like, wishing, God, I wish I could walk normal, I wish I didn't have a cane or whatever.
Yeah.
It's like, you don't really have to worry about that. Nobody's gonna come up and heckle you or anything.
Exactly that.
I just feel like, I'm not one of the beautiful people, so don't worry about it. Just jump in and do it.
Yeah, I would say 2 parts. I think not caring as much, which is a hard thing to do, because everyone there is trying to better themselves, and they're all coming in with their own problems that you don't know about.
Right.
Yours is just a little more visual. So not caring, which might be your own battle. And then 2, just showing up.
Yeah.
You don't have to do a lot, just show up, build a consistent program.
And a couple of times when I've gotten gym memberships, I'm like, oh, okay, I'm gonna go buy these great clothes and everything's like, you don't have to have all that. Just put some clothes on and go to the gym. You don't have to have all the stuff and everything. That's not gonna make you feel better.
That's usually what I do too. I feel like if I keep buying stuff, I'm gonna be more consistent.
I gotta have the phone, I gotta have the strap on my arm, I gotta have earbuds,
Yep.
I gotta have the cool shorts, and like, those things are gonna make you feel better for about 5 minutes because you have them.
Yeah.
That's not gonna get you to your goal of endurance, getting through the day without feeling tired, being able to lift gear that I have to lift on the weekends to load my truck up and unload.
Sure.
I just want to feel more confident about doing those things. Even though a Saturday for me, when I go do a full wedding, it's a workout. It is a marathon.
Yeah.
I get started at 8 and I get home at 2 in the morning. But by the time I get home at 2 in the morning, sometimes I feel good because I've been moving and stuff.
Yeah.
Because I've had to.
Yeah.
I'm getting paid to do that. It's hard sometimes to figure out how to pay myself on a day when I don't have a wedding to do.
Right.
And I'm sitting here going,
You know, I always say, I never regret the workout I do.
yeah.
I'm never sorry I do a workout. When I'm sorry is when I don't.
Exactly, yeah.
Sometimes I'm sorry the next day when I can't like
Well,
wash my hair.
Yeah, you can't lift your arm
Yeah.
or sit down on the pod.
Yeah, right. But it's a good kind of bad,
It's a
right?
good bad.
Yeah, maybe making your workouts like more applicable to like what you said. Like I have all this gear that I need to carry. So like if you're carrying it in 2 hands, maybe you're picking dumbbells up and carrying that, and that's your workout. And it's less than what you're working, but you're going to build up to that.
Yeah, that's a good thing because like sometimes I have a speaker bottom that's about 40 pounds. I can pick it up and walk with it and carry it, but I have to be very careful because I could take a tumble. So I'm very careful, but I have a cart. So I make everything super easy for me to move with. If I've got a cart, I can load a cart up and push it and it's no problem.
Yeah.
It's when I've got to carry something across a room where I start to expose myself to possibly having a fall or something.
Yeah, and
They
that
become less frequent because I've learned how to move or my limitations of movement so that I don't have that fall.
yeah, and fall recovery is important too. Like how you fall is important. So we train that.
I've kind of learned how to take a tumble
Yeah,
and protect my phone.
yeah, yeah, yeah.
Sacrifice a shoulder
Right.
that do my phone.
Exactly.
But yeah, I've learned how to take a tumble because when I first got out of the hospital, I had a couple of falls that were really bad.
Yeah.
But I've kind of learned how to drop and roll.
Yeah. Or it's slowly building up, like you're saying, you got to carry something that's your biggest problem. Well, maybe start with 5 pounds in the gym, make that very good, build it up to 10, and then all of a sudden, it's heavier than your equipment, right? The workout's now harder than what your task is, and that's the goal.
Makes it easier.
Right.
Yeah, that's a really good motivation.
Cool, I'm motivated.
Yeah.
Go get 'em, buddy.
Any other questions for Jamal?
Thanks, Jamal.
Yeah, you're welcome. Thank you for coming.